sharing your screen.
Okay, so you still can't see the slideshow.
So you're not sharing at the moment.
Okay, right. Just bear with me.
So once you've got it on slideshow, if you then click share on the top right, oh, that looks like it's working.
Have you got that on slideshow?
So we can see it, but it's not large. It's still slightly smaller.
That's
but if it doesn't work, don't worry, because it's still pretty big.
It would just be nice to get it so the the photos are as big as possible. I don't want to waste everyone's time because time is short.
If you, Louise, if you stop sharing and come back to Teams.
Yep.
Sorry, everybody. If you come back to Teams and then click the share button up on Teams.
Yeah.
And then you should be able to share. It should say something like PowerPoint Live. So you should be able to find a PowerPoint if you have it saved. Otherwise, you can scroll all the way down to the bottom, browse my computer. If you have it saved somewhere, that should help. I'm so sorry, everybody.
No, that's good.
There it is. Yeah.
Okay. Is there a better display than that, or is that the one to go with, do you think?
That one's perfect for our side. That looks great. Yeah. Oh, we can see pediatric skin problems overview.
Yeah. Okay. Lovely. So thanks for having me. I will talk until past. My slides might run slightly over, but I will just stop at past. And then if there aren't that many questions, I suppose we could do the last few slides. So I am just going to talk through some of the things that we and you see relatively commonly, some less common stuff. Some of this stuff is things that I think we as secondary care paediatric dermatologists feel it's good for you to be really confident on. And some of this is stuff that you're probably not seeing very much of, but it's just, good to have a bit of a feel for. And some of this stuff is things that come through A and G on a relatively regular basis. So the kind of the breakdown is a few slides on birthmarks, bit on infection, and then just a few slides on a sort of hodgepodge of things. So I am sure you all recognise these photos as being infantile hemangiomas. The second one, the slightly flatter one, is starting to involute, which is why it's slightly paler and flatter. And as I'm sure you are all aware, these are really common and they are harmless. They're a type of vascular tumour. The really key thing about infantile hemangiomas is that they're not present at birth. So if there is a vascular lesion present when the baby is born, it is not going to be an infantile hemangioma. There might be a little dot and, occasionally maybe the suggestion of a little sort of vascular area, but as a rule, they are not present at birth. Again, as I'm sure most or all of you are aware, they grow rapidly, particularly in the first 6 months of life, but they can grow up to 9 or even 12 months. And then at that stage, they stabilise, they stop growing, and then they gradually regress and involute over a period of a few years. And I kind of tend to say to parents that by the age of 5, about 50% of these lesions will have gone. And by the time they start secondary school, about 90% to 100% will have disappeared. We've had scenarios in the past arise because of the benign lesions policy and the BNSSG benign lesions policy, whereby some hemangiomas that we probably should have seen early because they needed treating haven't got through to us. So I think it's just important to be aware of the lesions that you need to refer, as I'm sure most or all of you are. Clearly, the vast majority of these are going to be small. They're going to be in non-critical sites and they're not going to need referral. But there are scenarios, as you know, that arise whereby infantile hemangiomas do need referring to secondary care. Some of those scenarios are when they are around sites where they might interfere with feeding or even breathing, so around the nose and the mouth, when they are in close proximity to the eye, and as they grow, they might interfere with visual field development. Infantile hemangiomas on the genital area, quite likely to ulcerate and therefore bleed and possibly get infected and cause problems. So any genital or perineal hemangiomas broadly need to be referred. If a baby has more than 5 infantile hemangiomas, do refer those cases because there is an increased risk of visceral involvement, and so we would usually organise an abdominal ultrasound, particularly to look at the liver for any liver involvement there. In situations where an infantile hemangioma is segmental, so these tend to be much flatter infantile hemangiomas covering a segment, usually on the face, but at other sites too. Those can be associated with syndromic features, so it's important that we see those because quite a lot of those will need treatment, and the treatments I'm talking about, as you're aware, are principally propranolol. So any infantile hemangiomas that are likely to cause problems, we would usually start these babies on propranolol. There sometimes is a sort of perhaps a sort of feeling from the families that they would like some treatment, but we feel that these babies don't need treatment with systemic propranolol. In some situations we use topical timolol, which can be helpful. It needs to be used for at least 3 months, probably longer, to know whether or not it's going to be effective, but there are some scenarios where topical timolol can be helpful. This is a scenario where this baby has a segmental infantile hemangioma on the face, and this baby is very little. This is the first few weeks of life, so the lesion has evolved and will continue to evolve. And so in this sort of situation where there's a segmental hemangioma on the face, really important to refer these babies. And this infantile hemangioma went on to evolve, pretty dramatically, as you can see, and this was associated with a syndrome which has an acronym called FACE or FACES, whereby there are intracranial malformations, so often cerebellar malformations, and abnormalities of the large blood vessels running intracranially, and also the cardiac vessels, and there can be cardiac anomalies as well. So any segmental hemangioma on the face, really important to refer those, and then obviously once they're with us, we can investigate as appropriate. Babies like this will need an MRI and cardiac investigations, and we would start a child like this on propranolol early. This is another scenario where I suppose it's sort of segmental. It's flattish and it's covering a fairly large area in the perineal region. Really important to refer babies with this sort of infantile hemangioma because, again, this has got syndromic associations. These sorts of infantile hemangiomas in the perineal region and the lumbosacral region can be involved with underlying spinal cord abnormalities, so often lipomas, and which are tethering the cord, and also bladder and occasionally renal abnormalities as well. So again, important to refer that group of patients, even though they are obviously less common than the usual sort of strawberry hemangiomas that we're all very familiar with. Just to differentiate what's known as a capillary vascular malformation from an infantile hemangioma. These you probably would encounter these possibly less commonly, but a capillary vascular malformation tends to be so would be present at birth. That will differentiate it very obviously from an infantile hemangioma in the same region, and they tend to be sort of more homogeneous as well, whereas an infantile hemangioma is a little bit more patchy, at least to start with. But these remain flat, and as I'm sure many of you are aware, and capillary vascular malformation in this distribution, that is involving the forehead and the eyelid, and often the maxillary area of the face, has an association with Sturge-Weber syndrome. whereby there may be blood vessel abnormalities intracranially, and also ocular involvement. So these children are at risk of developing glaucoma. So it's really important, if you encounter any capillary vascular malformations in this distribution, that they're referred. It can be initially to us, but really important they have ophthalmology review, and these babies need an MRI. They sometimes go on to be treated with pulse dye laser as well, with often really good results actually on the face. So these cases would tend to be picked up neonatally, and we would get the referral from the neonatal teams, but occasionally they're not, and they present by other means. So this is a warty lesion, happens to be on the leg, but these can arise pretty much anywhere. This is an epidermal nevus. So a type of birthmark that would usually occur in a streak or in a plaque, and they usually follow Blaschko's lines, which are lines that are of migration that are taken by epidermal cells during intrauterine life. And small nevi, like the one I just showed you, are harmless, not associated with any systemic problems, no sort of syndromic associations, and they're really just a cosmetic thing, and often your parents are quite concerned about them, and they'll be worried about the sort of the cosmesis and so on. Small lesions can be excised. They would, probably quite likely to need approval of an individual funding request, but obviously that if they're small and they're going to be easy to remove, that's a potential option. Otherwise, they don't need any further investigation. There is an entity called epidermal nevus syndrome, where epidermal nevi are associated with extracutaneous abnormalities of the brain and other systems. But if you're seeing a child with a relatively small lesion who is otherwise well and doesn't have any other systemic problems, that's what you're dealing with. It's just a straightforward birthmark that doesn't need any further investigations. But obviously we do sometimes, if the diagnosis is a bit uncertain, we do see these cases referred either via A&G or to our clinics. But you can reassure. This is a sort of slightly pinky yellow lesion on the scalp, which is by and large hairless, and this is a sebaceous nevus. I'm sure most or all of you will have come across these. They're not that uncommon. Years ago, it was thought they were associated with an increased risk of skin cancers, including SCC actually, but that's not felt to be the case now. And there is a rare association with BCC, but most commonly they can just produce benign hematomas or growths, usually in adult life and often in much later adult life, and actually there's no association with high risk skin cancers. So we would tend to, when we have these patients referred to us, we by and large would reassure, occasionally do a biopsy if we're not sure of the diagnosis, but usually just reassurance and conservative management. I haven't sort of seen a patient where parents have been really keen to have one of these excised for a long time, and I must check the recently I think worded benign lesion policy, because I would imagine probably these would need approval of an individual funding request now. But as I say, usually when these are referred to us, it's just a case of reassurance, and we don't do anything more, and just advise the families just to sort of keep an eye on them. If they develop any lumps and bumps within them, to ask for further review, but we wouldn't keep them under routine review just for a sebaceous nevus. So these are cafe au lait macules, which again I'm sure you're all really familiar with. They're really common, and it's really common for individuals to have one or two or possibly more. They are one of the first signs of, or the first sign of neurofibromatosis, and individuals with NF do usually develop these in the first year of life. They've either got them at birth and they develop and or they carry on developing them through the first year of life. But they're also common, without any underlying disease association. So we often do get individuals referred with several cafe au lait macules. And they don't go on to develop NF. But I think that the key take-home message really, as far as cafe au lait macules go, is that they pre-pubertally, they need to be more than 5 millimeters to sort of fulfill the definition of a cafe au lait macule, and post-pubertally they need to be more than 15 millimeters. And if there are more than 5 lesions, then they need to be referred. So up to 5 is considered okay, but more than 5, increased risk of there being underlying NF. So those patients need referral, and they sometimes go the way of genetics first. They sometimes come to us, and they at some stage should go through ophthalmology. So I guess whichever specialty you feel inclined to refer to, but a lot of them do come our way, and we would then refer on to ophthalmology and possibly genetics too. So some infectious problems that we encounter fairly frequently, and I'm sure you do too. You will all recognise impetigo. So the picture on the left is of non-bullous impetigo, which just tends to get called impetigo, doesn't it? And then the picture on the right is bullous impetigo with those large blisters. So non-bullous impetigo is usually caused by Staph aureus, but sometimes group B strep, Strep pyogenes. It affects all ages. I'm sure you've seen it across the spectrum, but tends to be commonest between the ages of 2 and 5. It often starts as periorificial, so around the nose, around the mouth, initially just with some erythema, and then often these vesicles with really thin roofs form, and so usually the roof comes off pretty quickly, so there's never really an appreciable vesicle or blister, and instead what you see is an erosion and then some yellowish crusting, which is a very familiar sign that most of us have encountered. The lesions would tend to heal in 2 to 3 weeks without any treatment, but obviously can be really quite problematic, especially if they're widespread, and that tends to be more common if eczema is present as well. Bullous impetigo is pretty much universally caused by Staphylococcus. And the blisters arise because of the specific exotoxins that are produced by certain serotypes of staph. That's more common under the age of 2 years, probably because as children get older, they acquire immunity to the various staph toxins. Tends to present with any size blisters, really, small ones, slightly larger ones, and really on any site, although we tend to see them on the trunk quite a lot. And one of the differences between bullous and non-bullous impetigo is that you can get some involvement of the buccal mucous membranes as well. Again, I'm sure you're all, I don't want to teach my grandmother to suck eggs, I'm sure you're all very familiar with treating this. But topical treatments are often the only thing that's needed if the problem is not widespread and if the child is well. So things like crysticide, which is 1% hydrogen peroxide cream, or fusidic acid or mupirocin for up to 10 days, and obviously advice as regards general hygiene measures, hand washing, keeping the areas covered and so on. And then for widespread infection, obviously systemic antibiotics are likely to be indicated. And if the problem is recurrent, we would always do a nasal swab to see if the person is a carrier of Staph aureus, and if they are, then recommend staph decolonization to try and reduce the frequency of episodes. And again, with recurrent episodes, I think it's important to swab the households as well, nasal swabs of household members, that is. Changing tack slightly, this is folliculitis. So you can see in the smaller picture these pustular lesions with perifollicular erythema. And then the larger picture, some slightly similar appearance, but probably slightly deeper lesions there. And, you know, you kind of get the sense that there's probably going to be some scarring there from a deeper folliculitis. Folliculitis can be either superficial or deep. The superficial variant is not always infective. It can just be sort of due to irritancy from sweat and friction and so on, but can still present with follicular pustules and this perifollicular erythema. You know, on swab, you know, there may be no growth. It may be just a sterile pustule. Deep folliculitis tends to present as often quite painful nodular lesions or furuncles or boils, and is usually due to Staph aureus. It's important in that scenario to, well, in both scenarios really, but particularly in deep folliculitis, where you're likely to be dealing with staph infection, to get confirmation of that with a swab that will really involve you getting some pus out, so trying to express some pus rather than just swabbing the, you know, the superficial part of the lesion. Again, if folliculitis is recurrent, as it quite commonly is in many people, it's really helpful to do a nasal swab to look for Staph aureus carriage, and then go on and do decolonization treatment. Again, with sort of deeper lesions that are tending towards boils, it's important to think about the PVL variant of staph, because that PVL staph is associated with deep boil-like lesions, and again, something that you're probably all aware of, but we have to remind our trainees when they come through that you have to ask the lab to look for PVL staph. They won't actually do the PCR to look for PVL unless you ask them to on the swab request. And in terms of management, so if this is thought to be a superficial sterile folliculitis, then it might be enough just to use some topical antiseptic, so washing with Dermal 500 or actinisan or similar. But in the case of staph-associated folliculitis, then you would want to treat usually with systemic antibiotics as well as topical antiseptics, and think about decolonization, obviously, if the nasal swabs are positive. Just worth mentioning malassezia folliculitis, so that's due to a yeast. Clinically, that tends to present with lesions on the trunk, so the upper part of the trunk and the shoulders. Less commonly on the legs and other areas. And just in patients who are just getting recurrent folliculitis, whether it's non-infective or infective, actually, you might want to think about a course of an anti-inflammatory antibiotic, something like one of the tetracyclines or possibly erythromycin if they're if they don't tolerate tetracycline or it doesn't work for 6 to 12 weeks. As much for its anti-inflammatory action as for antibacterial action. So yeah, a sort of 3-month course of limecycline or something like that can often be quite helpful in recurrent folliculitis. So we sort of went through a phase, I think it was last year, of seeing lots of this. So perianal streptococcal infection, it's dropped off a bit this year. I'm not quite sure why that is. I don't know how much you encounter that in primary care. So presents often with sort of pain and itch, pain on defecation, bleeding, sometimes some fissuring. And this is a variant of cellulitis, common in preschool and primary school age group, usually caused by group A strep, and often really quite symptomatic. So really important to to do a swab, and if that identifies group A strep, then to treat with oral antibiotics. This is often quite difficult to treat, actually, and and often these patients do come back, and even if you've treated them successfully with a course of oral antibiotics, often they've sort of reinfected themselves probably, and they come back a few months later with a further bout of perianal strep. But yeah, so important to treat with a 7 to 10 day course of oral antibiotics. And generally speaking, I mean, the lab, the microbiology lab, might not feel overly happy about using Augmentin, but I've sort of found that actually Augmentin tends to work better than other antibiotics, or clarithromycin as an alternative. And as I say, it frequently recurs, and then as the child gets older, it usually it resolves. So moving on to viral infections. So I don't know how much you see of this in primary care. I guess we don't see a lot of it here. You probably see a bit more than us. So this is the characteristic sort of maculopapular rash of measles. And those are the Koplik spots, which usually appear about 2 days before the exanthum appears and lasts then for a couple of days or so. So if you see those, obviously that's really helpful in confirming the diagnosis, because the rash of measles overlaps with a lot of other viral rashes, and sometimes it can be really difficult to make the diagnosis just based on the appearance of the rash alone. But I suppose key things about the rash of measles are that it starts on the face and spreads distally, can leave fine desquamation, so fine dry skin as it resolves. It's preceded by a fever and the 3 C's, and patients are often really quite unwell. And I'm sure you're familiar with, you probably know a lot more about measles than I do, and familiar with the potential complications, which are obviously really serious. So it is important to identify it, and obviously the treatment is just supportive, but really important to try and make the diagnosis if we're able to, and differentiate it from other rashes that actually look really similar. So this is rubella, but the rash is not as florid, and the patients are just not as unwell with rubella. So it's really sort of the clinical features that help you differentiate, because usually patients with this viral infection are just not as unwell. I'm sort of conscious of time, so I'll just whiz through maybe just for another sort of 5 minutes. So this one, again, I'm sure you're already familiar with this, probably see more of it than we do. So this is parvovirus infection. So called fifth disease, or erythema infectiosum, causing that slapped cheek appearance. So that's really characteristic, these bright red and slightly edematous cheeks. And then these children quite often develop a rash on the body, and as that resolves, it has this sort of slightly lacy, reticular sort of look to it, which you can sort of see a little bit there on the arms and on the chest. Key things to say about that. Well, you can see sort of the age group where you need to be thinking about it. Can be associated with the mild prodrome, but often these kids are not particularly unwell, and the rash can sometimes be itchy, and sometimes it can recur actually, even if when they've got over the viral illness, the rash can sometimes come back a few weeks later. Other things to kind of differentiate. So this is sixth disease, or roseola infantum. I don't know how commonly you see this. I would imagine probably relatively commonly. This is associated with really high fever, often for a few days, and then that settles, and then the rash starts. But the rash itself doesn't actually last that long, and it's self-limiting, and usually the recovery is pretty straightforward, although it can be associated with convulsions. So this is the rash of scarlet fever, described as feeling a bit like sandpaper. So I don't know if if you've sort of felt the rash, but it often does feel, you run your fingers over the skin, it does feel like sandpaper, and patients often have this sort of characteristic strawberry tongue, so that's another clinical sign to look out for. Just sort of thinking of sort of key things there. Obviously it's a clinical diagnosis often, but if you want to try and confirm it, sending off blood for anti-strep licenol, antibody titers can be helpful. And we all know about the treatment and the potential complications, so obviously really important to identify and treat it, and there obviously has been a lot of it around in the recent past. So this is hand, foot and mouth disease. So this is caused by the Coxsackie virus, characterized by, initially just little areas of erythema, then progressing to little blisters in the distribution as described. It's the ulcers in the oral cavity tend to be sort of yellowish with these slightly red borders, often quite painful. The classic sites are obviously involved, but sometimes there's involvement of the buttocks as well, and occasionally other sites too. It is associated with complications. There's no specific antiviral treatment for it, as I'm sure you know, so it's just conservative management. Important to be aware of something called eczema coxsackium. I don't know whether many of you have seen this, but this is Coxsackie virus affecting the skin of children with eczema. So eczema coxsackium presents with vesicles, bigger blisters, so bully and erosions as well when the tops come off, the vesicles and the bully. The lesions are much more widespread than in hand, foot and mouth disease, so they can be all over really, but they do often localize to the areas affected by atopic eczema, not always, but they can localize to those areas, so often the sort of flexures. And with eczema coxsackium, there is less oral involvement than there is with classic hand, foot and mouth disease. So this is HSV presenting as gingivous stomatitis, which is the commonest presentation in the of HSV1 in the pediatric age group. This is often associated with the prodrome and lymphadenopathy as well, and then often, very widespread, quite florid involvement of the lips and the gingiva and buccal mucosa and tongue as well. Usually resolves within a couple of weeks, and you'd want to treat this with acyclovir. This is obviously one not to miss.
Question there, if you don't mind me interrupting.
Yeah.
Does eczema coxsackium need any intervention?
Just supportive management. So there's obviously no specific antiviral treatment. It's sometimes quite difficult to differentiate it from eczema herpeticum. And so, if you're worried that, if you think it might be eczema coxsackium, but you're not sure, and you think that it might be eczema herpeticum, then obviously just treat with acyclovir and send swabs for PCR. If you are trying to pick up the Coxsackie virus, it's quite good to do an anal swab, actually. I mean, we probably do this anyway, but maybe, I don't know. But that's quite good at picking up Coxsackie. So until you get the viral PCR back, if you're just not sure whether it could be herpeticum or coxsackium, just treat with acyclovir, and obviously stop it if it comes back as PCR positive for Coxsackie. Otherwise, it's just supportive management. And if they've had quite bad eczema and then they've got the Coxsackie infection on top, probably you want to, wait sort of 48 hours or so into the infection until the lesions are starting to crust over and heal before you put topical steroid on. And I probably wouldn't go putting potent topical steroid on initially. I'd probably use something that's of moderate potency for the initial few days, just because obviously you don't want the viral infection to get worse if you're putting an immunosuppressant on the skin. But yeah, otherwise just sort of conservative management really. Yeah, peticum, again, I'm sure you're all familiar with, and obviously really important not to miss. These children can be really unwell. And if it's involving, so clinically, it presents with these kind of punched out, quite, so we call them monomorphic, they all look quite similar lesions that can be, kind of little blisters, which rapidly progress into erosion, so you may never actually see a blister, and then they can be quite crusted. And if it's on the face and there's the suggestion of any eye involvement, really important to get ophthalmology to review and look for evidence of HSV disease involving the eye. And if you suspect this, obviously really important to do swabs for viral PCR, send bacterial swabs as well, because often there's co-infection with staph, and start oral acyclovir and flucloxacillin as well, usually. So I'm just conscious we've only got a few minutes left. So shall I just rattle through until the end, or do you want
so
to take a couple of questions?
I put the feedback link in the chat and the sign up for the next one. So we are going over. So if people do need to disappear and go to their clinic, that's fine. The full recording for this will be uploaded on the CYP page of the BNSSG Training Hub. So if people do have to go and they want to finish the rest later, that's okay. But otherwise, if this is really useful, Louise, I'll let us go over and let you carry on if that's all right. But any questions, just pop them in the chat as we go. Sort of thin, scaly patches on the scalp. Again, I'm sure all of you will have seen this presentation because it's really common. So tinea capitis, commonest in younger end of the spectrum, primary school children, usually presents with itchy, scaly patches on the scalp and often hair loss. Really important to send scrapings and ideally some plucked hairs for mycology before starting treatment with oral terbinafine. Oral terbinafine, we all use it quite a lot, and I suppose we all feel familiar with it and fairly comfortable with it. But it can have some, potentially really terrible side effects, which you do encounter if you sort of used it for long enough. And so I think it's really important to get a mycological diagnosis to make sure that you're justifying starting a child on terbinafine orally. So really important to send scrapings. They can sometimes be difficult to get, not least because you've got a child who doesn't want to sit still. I don't know whether all of you are familiar with doing with scraping skin to send off specimens to the mycology lab, but it's quite useful if you've got one to use a stitch cutter. So the concave bit of the stitch cutter is sharp, but the convex bit is blunt, and so you can, even though it looks a bit alarming when you get out of the packet, if it's nice and blunt, so you can scrape that usually quite effectively over the skin to obtain a sample. Sometimes using a sterile toothbrush as well can help. We would use, it's not licensed, but as I'm sure many or all of you know, we would generally speaking use terbinafine as the first line agent for tinea capitis, not griseofulvin. Most tinea capitis is caused by various species of trichophyton, mostly Trichophyton tonsurans, and terbinafine works best for trichophyton species. The exception to that is Microsporum canis. Griseofulvin actually works best for that particular fungus. So again, another reason to get a mycological diagnosis so you know that you're using the right agent. Even though terbinafine isn't licensed, that's what we use. It's in the BNF, weight-based dosing. It's not available as a syrup, which is annoying and obviously means that the tablets need to be cut up and crushed and so on. And then important to also prescribe some ketoconazole or selenium sulfide shampoo to use usually a couple of times a week, just to limit the shedding of fungal spores, and ideally get the other family members to use that as well. So this is a carrion. So this is fungal infection that has been around for a long time and has produced a lot of inflammation. You get this sort of boggy swelling usually on the scalp. There's often quite a lot of pus, lots of exudate, and it looks a real mess. Often this is mistaken for an abscess, but it's really important to make that differentiation and to not try and refer to the surgeons for incision and drainage. So these carrion lesions are best treated with terbinafine. So same treatment. Often really help by just cleaning them up. So if we can get one of our specialist nurses to come and pick off all the crust and get rid of all the the pus and so on, give them and all the often there's a lot of hair that comes off with all of that crust. So cleaning it up and then starting on taking a sample and then starting on on terbinafine as well. Even though they are really pussy and boggy and so on, that's it's unusual for there to be coexistent bacterial infection, so you wouldn't usually need to prescribe an antibiotic as well as terbinafine, and they need fairly prolonged treatment, so 3 to 4 months. This is something which has been a big problem for many of us over the last year or so. So scabies is highly contagious, as you all know, causes an intensely itchy rash. In babies, will often present with lesions on the hands and feet, so on the palms and soles, as well as other areas. I mean, scabies lesions can occur anywhere, but yeah, look out for it on the palms and soles in babies. But you know, it obviously that they can be very widespread lesions, intensely itchy. Sometimes, depending on how familiar you are with dermoscopy, sometimes you can get some helpful clues when you identify, if you can identify a burrow and you can see part of the scabies mite within the burrow, and it produces a triangular a shape which gets called the delta sign. Sometimes that's helpful if you can spot it, but often that's very difficult. But if you've got a high index of suspicion, as we have all been doing for quite a long time now, treating with 5% methrin cream, and obviously repeating that. Really important to treat household contacts. I'm sure this is, you know, kind of, this is bread and butter for you all. But with the scenario that we've had recently, where it appears that possibly there's some resistance to topical treatments, we've been prescribing more oral ivermectin. Ivermectin, obviously, that was a red drug, wasn't it? But now you're able to provide to prescribe it in primary care. But with children, I think if the children, it's weight based, and so if the children are below 15 kilograms, yeah, do refer to via A&G if you think that they've got scabies which hasn't responded to topical treatment and you want them to go on and have ivermectin. And often the itching persists for several weeks, even after it's been fully treated. It's meant to be just for 6 weeks. Sometimes I think it goes on for a bit longer, and various topical treatments can be tried, but Urax HC is often quite helpful. And I think I'll probably stop there because we're running out of time. Actually, maybe if we've just got one more minute, because this has come through on A&G a few times recently. So this is perioral dermatitis, which is a sort of rosacea-like condition where you get little papules and pustules. Can be around the mouth, hence the name perioral, but actually it also gets called periorificial because you can get them around the nose and also around the eyes as well. So yeah, so acne or rosacea-like rash in that distribution. Sometimes there's a history of eczema, and classically perioral dermatitis is triggered by using topical steroids on the face or having other exposures to steroids, say for example inhaled steroids via a mask. But families find, you know, if they treat the child's skin with topical steroids, that can help a bit, but then when they stop, it gets loads worse. And so if this is what you think the problem is, because there's been a good history of steroid exposure, then you would probably want to try some of these things listed. So calcineurin inhibitors and sometimes topical antibiotics, or even topical ivermectin, sort of, you know, maybe that'd be third or fourth line. Oral antibiotics are rarely needed. But I think it's just worth emphasizing that actually it's not that common in children, really. I think we get quite a lot of stuff coming through where the referrer thinks it's perioral dermatitis, but actually probably, you know, it's something else. So it could just be atopic eczema with some perioral involvement, which is, you know, at the end of the day, that's much more common in children, or lip lickers dermatitis. I suppose that lip lickers dermatitis does look quite different, because often it's just sort of confluent areas of red dry skin that are in continuity with the vermilion, although not always. So that's probably easier to differentiate, but I think probably quite a lot of the time it is just atopic eczema and it's not true perioral dermatitis. So it's, you know, often difficult to sort of tease that apart. And obviously, if you're not sure, just refer via A&G or, you know, or to clinic. But I think just important to think about those entities, and that just because, you know, the child has a rash around the mouth that's a bit papular, it's not necessarily sort of perioral dermatitis. It could be eczema, or it could be something else, for example, lip lickers dermatitis. So I think I'll probably stop there because we're out of time, aren't we?
Brilliant. Thank you very much. So if anyone's got any burning questions, feel free to put them in the chat. And can I just say thank you very much, Louise, for that. That was absolutely fantastic. That was a really, really helpful presentation. And if people are able to do the feedback form, which is in the chat and will also be sent out by the email in the post-session feedback, that's really, really helpful, because it's helpful for the speakers. It's also helpful for us guiding future sessions. So that would be brilliant and much appreciated. And it doesn't look like there are any questions at the moment, Louise, so we'll just say thank you very much. That was brilliant.
You're very welcome. Would you like me to send the slides to you?
Yeah, if that's possible, I'll send you an email after this. And the easiest way, if it's too big, is probably just changing it into a PDF format rather than actual slides. And if you're happy to, then we'll send that out in the post-session email as well, and that'd be really helpful.
Yeah, that's fine.
Brilliant. Thank you very much. Thanks for joining, everyone, and take care. See you next time when we are looking at UTIs, another paediatric nephrology. So another good one to sign up to. Right, take care.
Thank you. Bye.